So we're looking at the knee in supine, and we're trying to move towards traction. So essentially separating the surface of the tibia from the femur. Now the primary reason that you would have to consider doing this is that the patient is presenting with some sort of knee pain. Upon motion testing, you've identified that there is some restriction in the knee. You would ideally work the soft tissue above and below based on what you find. So something as simple as going perpendicular to fiber direction on the quadriceps. So superficially, you agree I need to come this way, right? So hopefully you can see her nodding. Pulling this way, I would need to work that, and then I can have a still muscle moving bone, so I can use the lower portion to mobilize the femur. So I can basically use the leg or the lower limb below the knee to mobilize the femur just due to connection, and I can work on that. I can work on the hamstring as well, pushing, pulling. I need to work on the side, so the medial side as well. That's just so that you get a picture of what you might want to do. You'd want to work on the calf as well, depending on, again, what you identify. But to simply show methods of traction, you can be standing at the bottom of the table and just pull on everything, or you can get right into the knee and be sitting, which is probably easier. You can do this standing, but to be fair, because of angle, so my arm is not at too steep of an angle, sitting is actually really good for traction. Plus, I can really get control of the femur. So I'm going to essentially try to stabilize the femur, and then all I have to do, because I'm facing down the table, is lean my body, right? So hopefully, due to shadow, you actually can see this. So you'd look right around here. There's a crease in the pant. You want to look right around here to see what's happening. Now, maybe it'll show up well, maybe it won't. Hopefully the highlight is there. But if you kind of look right at this crease, you should see it. You can see a pulling away, right? Now, if I'm on the pant leg, it looks bigger. If I'm off the pant leg, you still see it. You agree that there's some traction there, right? So essentially, it's stabilizing the femur and then going there. Now, because I have palpation, I can sense, right? Now, right? Actually, no, it's not really going much past the knee. Yeah. That's nice. I'm extra good today. Anyways, your other option for tractioning the knee or for generating movement of the tibia and the femur away from one another, essentially all the way around, is still a wedge. In the case of a supine patient, I don't have to use my hand. I can actually use a much more powerful wedge in my forearm. Now, the forearm tends to be narrower at the wrist and wider at the elbow, just how most people are built. Usually, I would stand for this. I think I can show it more or less while I stay seated. So my forearm goes right behind the knee, and I literally just do that. I do that, and then I can kind of see what's going on with the knee. This one, yeah, does it feel like it needs to go that way? Right? So I can get my minor rotations, my wedge. Now, I'm not in the perfect spot, but that's what it would look like. Ideally, this works better when I'm standing. So hopefully, now the problem with standing is I'm going to obscure it, but literally like that. You start to feel some pressure around the whole knee. Yeah. She's nodding yes. I do this. I wiggle it. All right. Really simple. Now, my ability to be sensitive to what's going on is very low. I feel my bicep quite a bit. My forearm is going to get squished. The 2-point discrimination on my forearm isn't great. I have to use my eyes, my peripheral vision to make sure that the patient isn't jumping or anything like that. But two really easy methods right here. And then I can get my rotations as is needed. Yeah, and even in this position, it needs to medially rotate. All right, so we've got, yeah, that is medial rotation, internal rotation. So many words. But yeah, more or less a straightforward thing. It's exceptionally similar to prone. In prone, standing does seem to work a little bit better because you have to, you get a better angle on stabilizing the femur. You can do this in seated and prone, but either way works.